Good morning. Today I'm going to discuss with you one of the important topics in the field of nephrology because it needs a special assessment, special management for a very vulnerable sector of population, the geriatric age group patients. So today I'm going to discuss with you the geriatric nephropathy under the following sectors. I start with brief introduction, then what's meant by renal aging, and then chronic kidney disease in elderly, definitions and guidelines. What about blood pressure, hypertension, and its proper management in elderly? How to use drugs proper in this age? What are the indications of renal biopsy? And what are the different expectations from the young patients to the different sectors of kidney disease, acute kidney injury in elderly, frailty, and renal replacement therapies, and then I'll end with conclusion. I like to start with this slide from the bulletin, reflecting that aging is increasing all over the world. If I start with United States, this is the United States population aged 65 or older. If we are here today, this is 46 million, and by the year of 2060, this is the expectation that the number of this population, 65 or older, will exceed 90 millions in the United States alone. Moreover, the sector of persons ages 85 and more will be increasing too. The aging world is not restricted to the United States of America, but all over the world. Here, this is the different regions in the world. You can find here the distribution and the percentage distribution of population aged 65 and over by region 2015 and 2050. So 2015 can look at here, for example, Asia includes large proportion of these elderly persons. And this is the expectation by 2050. Here I want to fix to the definition of old, because old age is different from country to country. But I think the most interesting and accepted definition for me is to stratify all the persons into old, and oldest old. Old from 65 to 74, old between 75 and 84, and oldest old 85 or above. This is a classification. Another classification is to consider 65 to 74 as young old, 75 to 84 middle old, and 85 or more as old. Whatever the certification, this is just to give you idea about the age of these persons. When we speak about old age, we speak about vulnerable group. We speak at decline of all body system reserve. Let us to concentrate on our topic, on the kidney, renal aging, and what's meant by renal aging. If I start with this nice article that discusses the substantial loss of nephrons in healthy human kidneys with aging, this is the data from 1,638 living kidney donor at Mayo Clinic and Cleveland Clinic. If we look at this figure, the figure shows that with increasing the age, what do you see? The number of non-sclerosed glomeruli, this means healthy glomeruli, decreases, and the number of global sclerosed glomeruli increases. This means that by age, there is decline of healthy glomeruli and increasing the percentage of globally sclerosed glomeruli with subsequent reduction of GFR. So we should deal with aged persons as special group of persons. This is the first point, nephron loss by aging. What about kidney volume and how to assess kidney volume? We can assess kidney volume by CT scan. We have the kidney cortical volume as reflected by this white bar. Gray one reflects medullary volume, and the black one total kidney volume. So within these ages, you can find stable volume, but with aging there is a change. This among 1,281 living kidney donor, cortical volume declines, whereas medullary volume increases, making total kidney volume relatively stable until about 50 years of age. However, after which medullary volume doesn't increase anymore, and the total kidney volume begins to decline, as you find here in these sectors of ages. So this is an important point. So the first point is the number of healthy and sclerosed glomeruli I mentioned in the previous slide, and here I stressed upon kidney volume. So there is the diminution of the kidney volume by age. Another interesting point is the sclerosis score by age. The sclerosis here, they looked at 1,200 living kidney donors. A sclerosis score is defined as total number of chronic histological abnormalities between any global glomerulosclerosis, any tubular atrophy, interstitial fibrosis, and arteriosclerosis. We can say score is 0, 1, 2, 3, 4. As you see here, 0, 1, 2, 3, and 4. What do you see? By increasing the age, there is tendency toward increasing the score of sclerosis. Another interesting point, the number of cysts. Number of cortical and medullary simple cysts increases by age. Among 1,948 living kidney donors. So this is just, so again, by aging, there is increasing global sclerosis of sclerosed glomeruli. There is decreasing of kidney volume and increasing sclerosis index and increasing number of cysts. What about GFR? Senescence or aging of the kidney is reflected by decreasing, progressive increasing nephrosclerosis with loss of functional glomeruli and decreased overall kidney function as determined by GFR. Here, this is measured, and this is estimated GFR, measured by clearance and estimated from formulas. So the decline in kidney cortical volume from nephrosclerosis is compensated by nephron hypertrophy of the remaining nephrons, most notable in the medulla. As the patient's ages go beyond 50, this compensation is less adequate, and total kidney volume begins to decline with declining of kidney function. So you can see here, with increasing the age, both measured and estimated GFR, as you find, is declining significantly in women and in men. A very important point is the functional reserve. Here we can say that the minimum required function of the kidney is preserved most of the time, whereas the functional reserve decreases with age. The kidney undergoes age-related changes, reaching full functionality after the age of 5 years, and suffering a slow but progressive decline in its regulatory range of function, starting at the age of 20 years, as well as in function in GFR at higher age. Just to understand, if you look here, the functional reserve is declining by age. The question is how to measure the functional reserve of the kidney. Is by using renal stress test through an oral protein loading, usually oral proteins, 1 gram per kg body weight. This is oral loading. In Mansoura Urgent and Referral Center, we have nice work done by to assess renal reserve by infusion of amino acids and dopamine. But the majority of renal stress test is by using oral protein load, 1 gram per kg of body weight. And renal function reserve was defined as the difference between the maximum value of creatinine clearance after protein load, stress GFR, and the baseline creatinine clearance, basal GFR. I want to just to stress, renal stress testing is safe, feasible, easy, and inexpensive tool that is able to quantify renal function reserve. So by aging, there is declining of the healthy glomeruli, increasing sclerosis, increasing number of cysts, and decreasing GFR and decreasing function reserve. What about cellular and physiological pathways? This slide shows that all these parameters decreased: vascular density and regulation, antioxidant capacity, telomere length, which is correlated with aging process. The shorter the telomere, the shorter the lifespan of the person, by the way. Autophagy declining. The clotho expression, clotho is responsible about anti-aging, so clotho expression declines with increasing age and oxygen delivery. So all these parameters decrease with aging. And all these cellular and physiological pathways increased by aging. Angiotensin II sensitivity, inflammation, we have what is known as inflammaging, pericyte activation and fibrosis, FGF23 expression, and other senescence pathways and oxidative generation. All these increased by aging. Let us go to a very interesting study. Here, this is the normal BAS sustained old glomerulus with a peroxidase stained podocyte nuclei. And here you can find in the Bowman capsule, Bowman space is proteinaceous material. Here, by the way, this is a normal podocyte nuclei, and here is the detached nuclei. And with aging, there is increasing proliferation of podocytes, as you can see by here. This is the mirror image, doubling of the nuclei. When the podocytes proliferate, it leaves its site as a protective function for the glomerulus, and it is lost here in the undetached in Bowman space. This is known as podocyte mitotic catastrophe. We can say that glomerular life cycle follow the star like, so it increases until hypertrophic stress induced protein leak, and then massive podocyte detachment, tuft collapse, and global sclerosis. So this study links the changes that occur with aging to the podocyte hypertrophy and then proliferation and attachment with consequent focal and glomerulosclerosis. So glomerulosclerosis can occur through this pathway by aging, usually global sclerosis. Regarding the this figure shows in a very concentrated manner the age-related signals. You can look here. There's increasing cell senescence. Increasing all these are pro-fibrotic signals, increasing vascular responses, inflammations increases, oxidative damage increases. So all these are age-related signals with subsequent structural and functional changes. Structural changes, glomerulosclerosis, the basement membrane thickening and decreasing in nephron size. And here the reduction of the GFR and reduction of tubular function, tubular dysfunction. So there is decreasing in sodium reabsorption, decreasing concentration capacity, and increasing transtubular potassium gradients, and decreased response to fludrocortisone. So a lot of functional abnormalities that put the elderly person in a state of more prone to dehydration and cannot regulate volume status. Again, this is just to summarize. We have clinical macroscopic changes. This is the mass, weight, and length. There is microscopic changes: glomerulosclerosis, interstitial fibrosis, pericapsular fibrosis, glomerular basement membrane thickening, arteriosclerosis, tubular atrophy. Clinical changes: progression of new chronic kidney disease, function and survival after transplantation, functional renal reserve, susceptibility to acute kidney injury, functional changes in the form of GFR in most patients, sodium reabsorption decreases, transtubular potassium gradients, decreasing urine concentration capacity, concentrating capacity. So renal aging is there with structural and function abnormality. What about chronic kidney disease in elderly? This was the World Kidney Day on 13th of March 2014, was concentrating on the kidney ages. So kidneys age just like you. This was the clear message from this World Kidney Day, and they concentrated on the health style in aged persons. One of important point in the aging, all of us know that chronic kidney disease is defined either by the presence of parameters of chronic kidney damage or reduction of GFR less than 60 ml per minute. This is a standard definition. So if we say that we have a person aged 85, does this definition is best fitting? If we find the estimated GFR less than 60, we will say this is a person with chronic kidney disease. These authors discuss this issue under this opinion paper, and they suggested that it's better to use age-adjusted estimated GFR. So for persons in the age of 40, 60 is underestimating the problem of chronic kidney disease, and it's better to use estimated GFR cut-off point 75. And for patients above 75, it's better to use estimated GFR less than 45 instead of 60 ml per minute to avoid overestimation of chronic kidney disease. I am happy because this year we have a specific European clinical renal best practice group guidelines for elderly. So this is a clinical practice guideline on management of older patients with chronic kidney disease, stage 3B. And you can find a lot of definition how to define if you look at this sector of guideline here, they recommend using estimated equations that correct for differences in creatinine generation rather than plain serum creatinine to assess kidney function in older patients. And they recommend that there is insufficient evidence to prefer one estimating equation over another, since all perform equally and the substantial misclassification can occur with any of these equations when used in older patients with differing body composition. They recommend the formal measurement of kidney function if more accurate and precise estimation of GFR is required. And they suggested using, this is an important point, is they suggested, the guidelines suggested, using chronic kidney disease epidemiology equation considering combined creatinine and cystatin C, and it can be considered as an acceptable alternative for the formulas. Again, this is a suggestion based on weak evidence of research. And they recommend taking account of kidney function when prescribing drug. This is a very important point that I advise all of us to look at kidney function when we prescribe drug, especially chronic drug prescription in elderly. They suggest that the 4 drugs with narrow toxic and therapeutic range, regular measurement of serum concentration can provide useful information for these drug prescription. An interesting question in this sector of the guidelines: what is the most reliable risk model score to predict the progression of chronic kidney disease in older patients with advanced CKD, estimated GFR less than 45 ml per minute per 1.73 square meters? This is very nice. They recommended that the 4-variable kidney failure risk equation, depending on the demographic data, perform sufficiently well for use in older patients with advanced CKD in this guidelines. This is the meta-analysis, a very interesting meta-analysis discussing multinational assessment of accuracy of equations for predicting risk of kidney failure. So 31 cohorts, including this number of participants with chronic kidney disease, 3 to 5, in more than 30 countries, spanning 4 continents. And this is the calculator you can find in Google. Just if you write the name, you'll find this variables, and just fill in the space, select male or female, and write the age in years, estimated GFR, and then urine albumin, creatinine, and you will find the answer, and then determine the race, and you will find the answer within the calculator, the expected prediction of renal failure and the progression. This is very interesting data, so it is very simple. This study discussed the issue of multimorbidity among the and correlating chronic kidney disease and patient outcome. So multimorbidity as a specific combinations of chronic condition showed an effect on mortality which would be higher than the risk attributable to individual comorbidities or morbidities. So the presence of comorbidities increase the risk of mortality. The most important predicting pattern for mortality was the combination of atrial fibrillation, chronic kidney disease, and visual impairment after 3 years. So it is better to target the multi-comorbidities in this aged population. You can look at the different morbidities: atrial fibrillation, COPD, malignancies, anemia, and chronic kidney disease. Here, yes and no. No and yes. The no is associated with better survival, and yes is associated with worsened survival. And this is the CKD and outcome, the rest of the classification. And it just to show the unadjusted Cox proportional hazard model of time to death for the most associated individual morbidities and the multi-morbidity combination at 3 years of follow-up. You can look here. 1 disease, it is the others. 2 diseases, the other increased. 3 diseases, more and more increase in the hazards of mortality. An interesting point: occurrence of hypoglycemia in patients with chronic kidney disease or low GFR in elderly. Here you can observe, this is for persons using antihyperglycemic medication. Here, the lower the estimated GFR, the higher the percentage and the number of patients develop hypoglycemia. This is for antihyperglycemic users, so you can find here, and this is for non-users. This means that hypoglycemia can occur, and the presence of chronic kidney disease, especially stage 4 and 5, is a risky situation for hypoglycemia. Another important point is the diet, and it's important to know what should we eat. even in elderly. The excess protein intake is bad. So excess protein intake relative to fiber, and fiber is good. We should encourage fiber eating because eating fiber leads to antioxidative, and it has fiber eaters enjoy a better lifestyle and a better cardiovascular state. So excess protein to fiber is evident to be bad and associated with problems of cardiovascular. Uric acid is bad too. The hyperuricemia is associated with deterioration of kidney function in elderly patients with hypertension. This to stress on the management of hyperuricemia in elderly patients with hypertension. Regarding gout, occurrence of gout in elderly persons, this is the cohort of patients including 280,000 persons aged above the age of 66 years. What you see, the lower the GFR and the higher of the stage of chronic kidney disease, the higher the percentage cumulative incidence of gout in men and women. Here the dialysis reduced uric acid, but here this is the percentage. If you compare stages, different stages, so you'll find stage 4 and 5 have higher incidence of gout in both men and women. And you can look at the number, because numbers don't lie. So here, if we are looking at women, this is a different GFR. Here, this is the incidence rate of gout. Here, 2%, 2.6, 4.6, 8. This means the lower the estimated GFR, the higher the incidence. And the same for men, the higher is either adjusted or not adjusted. The same information, this is 3-year cumulative incidence of anti-gout treatment, allopurinol and or colchicine. Here, with lower GFR, there is increasing the incidence rate of using these medications for both women and men. A very interesting point they found in this study, that the using allopurinol is a friend, and the treatment of hyperuricemic patients with allopurinol over an age of resulted in a significant improvement of kidney function in this male cohort from the veterans administrative healthcare system. Clinicians should consider this potential benefit of allopurinol in the treatment of patients with hyperuricemia, because as you see, this is the uric acid before treatment and after treatment. Uric acid decline in the patients who received the allopurinol in comparison to the control. So it is rational that uric acid decreases when we use allopurinol. But the most important is, in comparison to the control, the dotted line, the GFR is preserved if the patient received allopurinol. If we reviewed the KDIGO guidelines for measurement of chronic kidney disease on 2012, the authors don't support or refuse treating hyperuricemia, and they left the advice to the treating physician, either to treat if he is interested in treatment, or to leave the using allopurinol because of they were afraid of the side effects. However, if we use the allopurinol in a proper way, and if there is established chronic kidney disease, we can start with a small dose and increasing the dose to the dose adjusted for the kidney function. Regarding blood pressure and hypertension in elderly, we may have isolated systolic hypertension, and this is a post hoc on treatment analysis of the Valish study discussing the issue of treatment blood pressure for isolated hypertension in elderly. In conclusion of this study, among Japanese older adults with isolated systolic hypertension, systolic blood pressure in the range of 130 to 144 millimeter mercury was associated with minimal adverse outcomes and a reduction in cardiovascular disease and all-cause mortality. So the first point here, systolic blood pressure between 130 to 144. And if we look at the results, we can look here. This is the lowest level of mortality, hazard risk for composite cardiovascular events. The lowest value is between the 130 to 144, and there is a U-shaped curve. The lower the systolic blood pressure, less than 130, the higher the risk, and the higher blood pressure above 144, the higher the risk. So this is a very important point, that the best here, according to the study, 130 to 144. If we look at this from 130 to less than 145, this is the reference. If the systolic blood pressure is less than 130, this is the composite cardiovascular events, and this is all-cause mortality. You can find all these are higher than 1. This means this level of systolic blood pressure, irrespective to the model of adjustment, this is not good for these elderly patients. And the same for high blood pressure. This is a U-shaped, classic U-shaped or G-shaped curve. So again, please concentrate on the key message of this study. Is systolic blood pressure to be kept between 130 to less than 145 to decrease the composite cardiovascular events. Again, the same. This is the cumulative probability of cardiovascular event free percentage. Here, the lowest cardiovascular events was met by this level of systolic blood pressure between 130 to less than 145. Less than 130, this is the increasing cardiovascular events, and above 145, more and more increase in the cardiovascular composite outcome. Regarding an interesting observational study showing the correlation of age and outcome with blood pressure in patients with incident chronic kidney disease, in this very big cohort of patients. So in veterans with incident chronic kidney disease, systolic blood pressure showed different association older versus younger patients. And if we look here, this is very interesting, showing the effect of blood pressure on mortality in these aged persons. You can see here, this is the color coding for systolic blood pressure less than 100, 100 to 10, 110 to 120, and then you can find here, what do you observe? This is a U-shaped curve. The higher the systolic blood pressure, the poorer the outcome. And here they compared, the reference is 130 to 139. Again, 130 to 139 is the best here, and you can find it to the age, to this very old age, and it is ameliorated here in the age above 80 years. Again, systolic blood pressure less than 130 and above and higher than 140 is associated with outcome, with mortality. However, you can find different association with diastolic blood pressure. Blood pressure and incident indecision disease, you can find the higher the blood pressure, systolic blood pressure, the higher the occurrence of incident end-stage renal disease. Very interesting. Systolic blood pressure displayed a linear association with end-stage renal disease. You can look and find the association is clear, whereas diastolic blood pressure showed no consistent association. Again, this is a randomized controlled trial discussing the issue of intensive versus standard treatment of blood pressure in persons aged 75 or more. For standard blood pressure, this is intensive blood pressure less than 120, and this is standard just less than 140. This very interesting study showing that or concluding that ambulatory adults aged 75 or older treating systolic blood pressure to less than 120 compared with systolic target of less than 140 resulted in significantly lower rates of fatal and non-fatal major cardiovascular events and death from any cause. So this randomized clinical trial gave a bonus toward intensive treatment of blood pressure. So again, this is systolic less than 120 and this is less than 140. This is the intensive and this is the standard treatment. Again, this is another randomized, another analysis to discuss the issue of effect of intensive blood pressure control on gait speed and motility limitation in adults 75 years or older. Here, the study conclusion among this sector of patients treating to systolic blood pressure less than 120 compared with target less than 140 had no effect on the changes in gait speed and was not associated with the changes in mobility limitation. So give another bonus. To the extent that in this editorial comment, hypertension in elderly, a sprint to the finish. Sprint, this is the trial, was randomized open label trial of community dueling older adults. The mean age is 68 years and the median follow-up is 3.2 years, that evaluated whether lowering systolic blood pressure less than 120 versus less than 140 reduced the major cardiovascular events. And the editorial here, a sprint showed that in hypertensive adults without diabetes, lowering systolic blood pressure to goal less than 120 compared with less than 140 resulted in significantly lower rates of fatal and non-fatal cardiovascular disease events and death from any cause. Just to show the data that there is a tendency toward proper control and more intensive management of blood pressure in elderly. But the most important point is to assess the tolerability of antihypertensive therapy, the occurrence of adverse events and side effects in these group of patients, the risk for adverse drug events related to age-related physiological changes, comorbidities, dosing and drug interactions. Adverse drug events can be significantly minimized by careful drug selection, appropriate dosing, and addressing polypharmacy. This is a very important point that I am going to tackle just 1 minute. Tolerability to antihypertensive agents relates to a host of factors and may play a significant role of non-adherence, a lot of issues. An application for the tolerability is the use of RAS blockade drugs, either ACE inhibitor, angiotensin converting enzyme inhibitors, or angiotensin receptor blockers in this cohort of patients with chronic kidney disease. The question of this paper is acute kidney injury in elderly patients with chronic kidney disease. Do angiotensin converting enzyme inhibitors carry a risk? This is a very interesting study, and just to show you, there is a differential pharmacokinetics between ACE inhibitors and the angiotensin receptor blocker. If we just concentrate on this column of renal and hepatic excretion for these drugs of ACE inhibitors, captopril, lisinopril, perindopril, ramipril, what do you see? The majority of the drug is eliminated through the kidney. And if we look at these 5 angiotensin receptor blockers, here the majority of elimination is through hepatic elimination. So there is differential comparison regarding the occurrence of this of the pharmacokinetics and elimination of these 2 classes of drugs. If we look at the results of this study, in comparison with the control, the incident acute kidney injury percentages is higher if we use either ACE inhibitors or angiotensin receptor blocker. If we compare the incident acute kidney injury to the different classes, the occurrence of acute kidney injury is more in angiotensin converting enzyme inhibitors arm. This may be explained by the different pharmacokinetics that I just mentioned. And the most important is the using overdose, and the dose adjustment is necessary. So in this study, community acquired acute kidney injury and the use of ACE inhibitor or ARBs in the emergency department were retrospectively assessed in 324 patients with baseline stage 3 chronic kidney disease. After stepwise regression analysis, the use of angiotensin converting enzyme inhibitors and the presence of dehydration were associated with acute kidney injury. So this is a very important point, and the study and the results of this study suggest that dose adjustment of angiotensin converting enzyme inhibitors to renal function or substitution of ACE inhibitors with angiotensin receptor blocker could reduce the incidence of acute kidney injury. Moreover, ACE inhibitors and ARBs should be stopped in cases of dehydration. Again and again, the tolerability to the drug and the occurrence of adverse events. So just to show the factors related in the elderly and its effect. So age-related physiological changes, alteration in body weight resulted from changes in the muscle, bone, lipid, and water compartment, decline in body water with age, relative increase in body fat, decline in muscle mass, alteration in gastrointestinal function, alteration in hepatic function, decline in renal function. All these are characteristic of aging. So we should think of all these when we prescribe medicine and follow up the adverse events. And the pathological disorders in gastrointestinal, with dehydration, hepatic dysfunction, kidney dysfunction, heart failure, etc. And interaction that influence the drug kinetics and dynamics, drug interaction, like using non-steroidal that blunt the effect of diuretics and ACE inhibitors on blood pressure control. Disease interaction, ACE inhibitors or ARBs may worsen pre-existing renal impairment and cause hyperkalemia. Diet interaction, polypharmacy. All these factors should be put in mind when we prescribe medicine for elderly. And the issue of polypharmacy is very important and crucial. If we look at this study, the findings of this study raise a cautionary note regarding the safety of using combination therapy, especially if the blood pressure is less than 130. Here, if you look at the survival percentage, here using multiple polypharmacy, more than 2 drugs, to control blood pressure to less than 130, systolic blood pressure less than 130 is associated with higher mortality and lower survival. The same here, lower systolic blood pressure with more than 2 drugs. Here, the best survival is attained by lower systolic blood pressure less than 130 and usage of less than 2 drugs or 2 drugs. But if we use more than 2 drugs, this will be associated with lower survival. This is an institutionalized individual older than 80 years. Again, the tolerability to polypharmacy is difficult, may be explained by increasing falls, etc. in this age. Again, I'm stressing in the role of allopurinol because allopurinol initiation for hyperuricemic hypertensive aged patients is beneficial and can be associated with improvement in blood pressure control. Regarding the sector of drug, which is very important, inappropriate medication or potentially inappropriate medication is significantly high in the aged patients. If we look at these 7 categories for inappropriate medications: indication without medication, medications without indication, contraindications or interactive side effects, dosage problem, double medication. You can find the prescription including 2 ACE inhibitors, so it is bad, wrong medication, therapeutic drug monitoring, so we missed to monitor the drug which should be monitored. So all these are inappropriate style of medication, and this is a strategy toward the solving the problem of inappropriate medication. We have a stop or start. Stop is the abbreviation of screening tool of older people's potential inappropriate prescription. Just stop inappropriate medicine. Start means a screening tool to alert doctors to start treatment if the treatment is missed. This is from Italian experience, showing discussing the issue of inappropriate medication. This study raised a very interesting answer. What about the percentage of potential inappropriate prescriptions? It is approximately 10% in this study. And we need to develop novel strategies aimed at improving the quality of drug prescription. This is the most important recommendation from this study. Another point of cardiovascular polypharmacy, the need of more drugs for cardiovascular medicine is associated with increasing risk of geriatric acute kidney injury from side effects, adverse effects, etc. Regarding the term de-prescribing, this is very nice. Here, this is de-prescribing of proton pump inhibitors. And here I'm going to discuss with you the proton pump inhibitor, because proton pump inhibitor is commonly abused, and the prescribing of inappropriate proton pump inhibitors in older adults is a growing area of clinical and research interest. Here there are a lot of concerns about abusing PPI. Long-term proton pump inhibitor is only recommended in selected population. Patients at high risk of gastrointestinal bleeding with Barrett esophagus or Zollinger-Ellison syndrome. Although PPI use is recommended for 2 to 12 weeks in gastroesophageal reflux disease and peptic ulcer disease, these drugs are commonly continued long-term without appropriate reassessment of the need for ongoing treatment. Inappropriate PPI, proton pump inhibitor rates in hospital are also high, ranging between 40 to 80%. On general medicine ward, continuation of PPI initiated for stress ulcer prophylaxis in intensive care unit after transfer to long stay wards and when discharge from hospital is also common. A lack of documentation of indication and recommendations of follow-up in discharge letters from hospital is a contributing factor to ongoing inappropriate use of proton pump inhibitors. De-prescribing is the process of withdrawal of an appropriate medicine. So PPIs have been recognized on a national and international levels as priority for the prescription and type of intervention, either to reduce the dose or cessation of medicine, because of many side effects of using proton pump inhibitor when it is not indicated. The complications of abusing PPI is increasing acute interstitial nephritis, chronic kidney disease, infections, electrolyte disturbance, hypomagnesemia, hypocalcemia, even fracture. So a lot of side effects because of the abusing of this class. This is a very good class when indicated, as I mentioned, and should be given for a temporary period of time. And the most important issue is to document the indications and the plan of treatment. The other point is drug adherence, and the evaluation of adherence is especially important in patients with resistant hypertension, for example, because non-adherence may lead to pseudo-resistance. So we should consider the non-adherence in all, not only for hypertension, but for all specialties. And we should tackle different strategies to improve drug adherence. And these are methods of adherence evaluation, either direct method and indirect methods. You can fix this slide and read the advantages and the limitations of every method. but which is important to be kept in mind. We should have an action to improve drug adherence. Here, this is an example of using patients and partner feedback reports to improve statin medication adherence, and it was useful and very interesting. Daily alarms combined with individual or partner feedback reports improved statin medication adherence, while neither an individual feedback nor partner feedback strategy created a sustainable medication adherence habit. The intervention itself is relatively easy to implement and low cost, and it's very interesting. Here, regarding the statin, so long as I'm speaking about statin, there is increasing incidence of new onset diabetes after starting a statin. Here I want to just to say that even in diabetic dyslipidemic or diabetic cardiovascular patient, we should treat by statin because the benefits of prevention of cardiovascular outcome outweighs the risk of diabetes. But what I want to stress upon, especially if we use high intensity statin, is to follow plasma glucose for early treatment. So over 10 years, almost 50% of Australian elderly women had filled a prescription for statin. During that time, 5% of women had initiated treatment for new onset diabetes. A 33% increased risk of new onset diabetes was associated with statin exposure. And if we look, the most important risk factor is the statin dosage. In comparison to the low intensity statin, the use of high and very high statin was associated with increasing hazard ratio of development of new onset diabetes. This to say, when we prescribe statin, especially the high dose or very high dose of statin, we should monitor for glycemia. Another point in elderly, using proper bowel cleansing for colonoscopy for surveillance of cancer. Complications are increased in elderly and need to be considered along with expected benefits prior to recommending this procedure. A split for liter polyethylene glycol preparation is highly effective and may be preferred for elderly patients with comorbidities because using oral sodium phosphate is associated with higher percentage of acute kidney injury in this vulnerable aged group, especially if there is chronic kidney disease or diabetes. Again, there are a lot of drug interactions in elderly. Even drug interactions may occur with foods. So the laxative, even laxative may cause problem of malabsorption of nutrients. Using isoniazid may be associated with pyridoxine deficiency. A lot of drugs can interfere, like carbamazepine and other antiepileptics, with vitamin B12 and vitamin D. The immunosuppressive drugs like cyclosporin or tacrolimus may have hyperkalemia, hypoglycemia as unintended consequence of cyclosporin is well-known side effects. So all these are interactions. So we should look at even the diet because these are the changes related with aging, and these are the consequences. So we should take care of that. Omeprazole has these consequences: decreasing vitamin B12, decreasing iron, decreasing magnesium, calcium. Again, I am stressing upon avoiding abusing proton pump inhibitors in elderly patients. And whenever we use RAS blockade, it's better to look at potassium, especially if there is chronic kidney disease. A lot of disturbances in electrolytes can be witnessed by using this drug. Metformin can decrease vitamin B12 and folic acid. Furosemide can be associated with hypocalcemia, hypokalemia, hyponatremia, hypomagnesemia, and lower vitamin B1. What about biopsy in elderly? What are the indications of doing a biopsy in elderly? All these are indications: acute kidney injury, rapid progressive glomerulitis, nephrotic syndrome, and acute kidney injury, nephrotic syndrome, unexplained kidney disease, asymptomatic renal abnormalities. All these are indications of doing a biopsy in elderly. The most important point, if we compare the elderly versus young, this is the black one refers to the elderly. If we are dealing with nephrotic syndrome, you can find in comparison to the young, minimal change and focal and segmental glomerulosclerosis are less occurring causes of nephrotic syndrome, while membranous nephropathy is more common in elderly person. IgA is lower in aged persons, and here if we are dealing with post-immune crescentic for acute kidney injury, you can find a higher percentage of post-immune crescentic nephritis and lower lupus nephritis as a cause of acute kidney injury. So if we put all this to increasing acute interstitial nephritis and acute tubular necrosis in the old patients in comparison to the young control. What about acute kidney injury? Acute kidney injury occur in elderly because they are more vulnerable, and here this from United States Renal Data System, the last report showing that cumulative probability of recurrent AKI hospitalization is common with increasing age. If we find old age person after doing coronary angiography with this appearance with acute kidney injury, we should think of atherosclerotic renal disease, and this is a classic histopathology here. After the processing of the tissues, you can find here this is cholesterol cleft because cholesterol within the atherosclerotic renal disease or cholesterol imbalance syndrome dissolved and left the cleft here in the biopsy. Regarding if we do biopsy and the diagnosis is ANCA-Associated Vasculitis, can we use immune suppression? Yes, we should use immune suppression if we are dealing with aggressive acute kidney injury with ANCA-Associated Vasculitis in elderly patients, but we should be careful about the occurrence of infectious complications, so proper giving and appropriate monitoring is mandatory. Another point, this is the last case report published within days. An elderly man, 76-year-old, who presented with ANCA-Associated Vasculitis in the biopsy post-immune crescentic glomerulitis, and when they reviewed all the medication, they found that the most accepted explanation is the use of hydralazine, because hydralazine was used to treat as antihypertensive drug. So this is the drugs that may lead to ANCA-Associated Vasculitis. A stronger evidence was by hydralazine and then minocycline, and all these drugs can lead to the ANCA-Associated Vasculitis, levomazole, if it is contaminated with cocaine. Weaker evidence base for all these drugs. So this is a very important point, to know the drug and to know how to deal with it. Let us to focus on hydralazine. Hydralazine may cause ANCA-Associated Vasculitis and may cause drug-induced lupus nephritis, and rarely we can find overlapping ANCA-Associated Vasculitis with lupus, and this is may be induced rarely by hydralazine. Hydralazine may cause ANCA-Associated Vasculitis through reversing epigenetic silencing of proteinase 3 and MBO, resulting in increasing suppression of both autoantigens in neutrophils to break tolerance and induce formation of disease-causing anti-MBO ANCA and antibodies. The MBO ANCA titer in this patient that was presented in this article, in this case, was anti-MBO high titer and the low BR3 ANCA in this titer, and negative anti-DNA, anti-nuclear antibody, and anti-histone antibodies. Here they started because of severe clinical presentation, acute renal failure, and lung dysfunction, etc. So they started steroid and plasma exchange, but with no appreciable response. So what will be the next treatment? No additional immune suppression, mycophenolate mofetil, cyclophosphamide, rituximab, or azathioprine. If you read in details the discussion of this case and answer of this question, the best choice is to use cyclophosphamide, because the patient was presented with severe syndrome, and the rituximab, yes, was assessed in many studies, but not for severe disease. This is the point. And the second important point is that rituximab was not tested enough in drug-induced ANCA-Associated Vasculitis. So KDIGO guidelines recommend in severe disease using cyclophosphamide either intravenous or orally to treat these patients. How to predict the outcome after acute kidney injury in elderly patient? This is a nice study showing that there is a correlation with low body mass index, low baseline estimation GFR, low pre-albumin, low albumin, and higher stage of acute kidney injury. All these are associated with poorer outcome after acute kidney injury. What about frailty? It's an important term because frailty was defined as clinical syndrome in which 3 or more of the following criteria were present. Unintentional weight loss, so we should consider the weight loss unexplained in elderly as a very important point, like 10 pounds in the past year, because traditionally there is some decline in body weight, but in the range of 200 grams per year. Self-reported exhaustion, so unintentional weight loss, self-reported exhaustion, weakness, slow walking speed, or low physical activity. And this study, if you look, this was a systematic review to review all publications until recent, because the paper was published in 2016. You can find here they tackled all, traced all articles regarding functional impairment, cognitive impairment, or frailty. So functional and cognitive impairment and frailty in patients reaching in a stage are highly prevalent and strongly and independently associated with adverse health outcome, and they may therefore be useful for risk stratification, and more research into their prognostic value is needed according to the recommendation of this article. How to know and assess frailty? This is a very nice score. They look at either phenotypic frailty scale based on question, fatigue, are you fatigued, yes or no? Resistance, are you unable to climb stairs, yes or no? Are you unable to walk, yes or no, 1 block? Illness, do you have more than 5 illnesses, yes or no? Loss of weight, have you lost 5% of your weight in the last 6 to 12 months, yes or no? Just yes or no. And we collect. Frailty is defined by score 4 to 5, intermediate frailty between 2 and 3, and if it's less than 2, this means no frailty, 0 and 1. And this is phenotypic frailty scale based on question and measurement. So it's better to look at these scales to know the patient frailty. And this frailty scale was used on assessment of the patients for transplantation. Regarding renal replacement therapy, a very nice study showing that the patient, this is including 28,000 old patients, and here this is the state of the either dialysis or the white color reflecting decision against dialysis. You can see by increasing the age there is tendency toward rejecting dialysis. So the patients have the right to select the best modality for their opinion. We have dialysis, transplantation, and conservative management. Here, according to the age, with increasing age, especially age 80 or more, there is increased tendency to decide against dialysis from the patient themselves. So it's not only the age, but also the comorbidities. If there is low comorbidities or high comorbidities, the higher the comorbidity score, the higher the percentage of patients who refused dialysis or declined dialysis. But I want to stress upon the role of physician to select the best modality. If we look at this incident patients, a total of 13,000 were over 65 years. And if we are here in this age range from 65 to 79 years, the median survival is 4.5 years. And here 2.7 years, above 80 years. So this means that the patient can live longer on dialysis with a reasonable quality of life if they are treated in a dignified and appropriate manner. This is just not astonishing. We should encourage mobility and even exercise on dialysis according to the patient's abilities. So the outcome was particularly favorable in terms of quality of life if we allow exercise for our patients, and there is special training for that. One of the important clinical questions: what about the vascular access for doing dialysis for elderly? This study includes 17,000 patients who started dialysis and on incident hemodialysis, and the age was equal or above 67-year-old. Here they looked at the AV fistula success or failure. You can find here 9,000 with AV fistula success and 7,900 with AV fistula failure. AV fistula success was defined as dialysis initiation using AV fistula with a time between AV fistula placement and dialysis. Here the success rate increased at the time from AV fistula creation to hemodialysis increased from 1 to 3 to 3 to 6 months. So if we look here this is the odds for success of the fistula. Here this success is low if the time interval between AV fistula creation and dialysis is between 1 to 3 months, but increase significantly to if we increase it to 3 to 6 months. But beyond that, if we start fistula, if we create fistula earlier and earlier, there is no increase in odds ratio of success of the AV fistula. But what happens when we create fistula earlier? The patient will need a lot of intervention to keep it patent. So we should compromise this issue, and I think 3 to 6 months is important when we predict dialysis. And generally speaking, timing for AV fistula in all patients, we should consider many factors, not only estimated GFR, but we both estimated GFR, the principal is stage 4 or 5 in elderly, the degree of progression of chronic kidney disease, so the trajectory is very important, development of any symptoms, and as well the age, as I mentioned. The age is very important, so we may be reluctant to create fistula in stage 4 in patients aged 70 or 80 years, and just to follow up the rate of progression of kidney function. But be careful if there is manifestations of malnutrition, etc. So timing of arteriovenous fistula placement, we should keep it in perspectives and do to think. This is one of the good clinical approach for selection of AV access for patients to start dialysis. If the patient is moribund, we may start dialysis even by catheter for these patients if they are unfit for fistula or graft. But generally, we look at clinical prognosis and vascular anatomy that guide us in selecting the proper way of arteriovenous access. So if we are dealing with patients aged 75 or more with no comorbid condition, we go ahead for AV fistula. But if there are multiple comorbidity, we may decline the idea of AV fistula and think of arteriovenous graft later on, just before the need of dialysis. And according to the prognosis, if the renal progress rapidly, we should think of fistula. So the trajectory of creatinine is important. And if the kidney progression is slow, we may decline fistula and to consider AV graft later to start dialysis through AV graft. Overall survival, so this is a kidney progression, this is overall survival. If there is no other life-threatening condition, we recommend the fistula. If there is presence of non-renal life illness, consider AV graft. If vascular anatomy is within this range, so there is a low risk of failure maturity. So if artery above 2 millimeter, vein above 2.5 millimeter, no stenosis or thrombosis, here we encourage fistula. So the key message is we like fistula whenever we are sure that it's the best for the patient to be created within 3 to 6 months before starting for the expected timing of dialysis. وboth the patient condition, the presence of multi-comorbidities, the rate of progression of kidney, and the overall survival of the patient. If the survival is very limited, we can decline even the ideas of the creating fistula altogether. Here this is the Italian perspectives, discussing the different choices of the vascular access in elderly. Here, preemptive AF fistula, the advantages are no age limit for this procedure, with adequate vessel, lower infection rates compared to catheters, better survival, and the patient can shower. So all these are advantages for creating fistula before starting dialysis. Disadvantage, competing risk of death before hemodialysis starts, so the best timing is judged by the proper and wise clinical judgment. Higher rates of failure to mature compared to AV graft, more AV fistula created than used. So all these are the problems of fistula. AV fistula after dialysis starts, surgery is as needed. Most functional AV fistula will be used. Advantage of preemptive AV fistula are maintained, but cardiovascular catheter here is needed to start dialysis. The problem is starting with catheter, and we should consider starting dialysis with catheter is unethical if we have time to do it, because using catheter is associated with high risk of infection, admission to the hospital, and even mortality. So if we are following our patients as nephrologists, we should create fistula whenever it is appropriate, as I mentioned in the previous algorithm. AV graft, short timing from procedure to use, lower insertion rates compared to catheters, but the problem higher cost, need accurate maintenance with interventional procedures. Cardiovascular catheter quick, easy, no needle puncture, higher patient preference. However, we should educate our patient by all harmful effects of the catheter use. Regarding the issue of dialysis, should we do dialysis for all patients, aged patients? This is a very nice algorithm published within the clinical practice guideline that was published this year about we should evaluate these patients thoroughly. So regular assessment for patient ages above 65 to assess the risk. We have here this score, and I'll mention it in the next slide. Banzali score. If the risk is high, yes, accept risk mortality. If risk of mortality higher than risk of progression, here we should share the patient in decision making, because the patient may even select the conservative treatment and avoid dialysis. And if the score is not high, but frailty is high, we go to the same direction. But if the score is low and the frailty is low, accept mortality risk is low, we also share the patient in the shared decision making, and here the tendency will be toward doing dialysis or accepting transplantation. Here, this is another kidney failure scoring to predict the outcome, and I'll mention it in the next slides. So according to we should apply the scores, and when we apply the scores and assist the patients and share the patient decision making, we select the best for the patient preference, and this is the most important point to be put in mind. Regarding Banzali score, this is a score depending on this variable age. So for the age above 85, we give 4 points. For this age, 2 points, 1 point, and 0 point for patients less than 74. Men scored 1. Race, black and white 1. Estimate GFR, the lower the estimate GFR, the higher the score given. Urine albumin to creatinine ratio, above 30 milligram per gram, yes, 1. Diabetic, yes, 1. Smoking, current smoking, 2. Former, 1. Prevalent heart failure, 2 or 0, according to present or absent heart failure. Prevalent stroke, yes or no. So the higher the score, the lower the survival and the more expectation of complication in this sector of patients. Renal score, another score, and these are the factors, risk factors, and the points of the score. You can look at the different factors and the given points, and this is the to classify patients into high risk, intermediate risk, and low risk. And for each group of patients, it's better to go ahead for proper management, to put in consideration the patient-centeredness or patient-centered approach. Another risk assessment in elderly, depending on these points. So this is the points for age, for albumin, less than 3.5, needing assessment, lives in nursing home, had or has cancer, had or has heart failure, hospitalized for more than 1 month in the last year, and this is the total score. If the total score is 2, the expecting mortality within 3 months is 2%, and 4% 6 months. But if the score is above 8, this means that mortality is 39% within 3 months and above 50% within 6 months. So all these are relative scores that can be applied. Another important point in dealing with hemodialysis in elderly is malnutrition because of age-related factors like reduced metabolic expenditure, loss of muscle mass, anorexia, or psychosocial and medical related like loneliness, dependency, poverty, dementia, satiety, polypharmacy, or CKD related uremic toxicity, metabolic derangement, inflammation, and dialysis related catabolism. And all of us know that the mortality in dialysis is related to MIA, malnutrition, inflammation, and atherogenesis. And the consequences of all these factors is worsening quality of life, sarcopenia, loss of muscle mass, frailty, and eventually mortality. This is a very interesting case that we faced here in our center at Mansoura Urology and Nephro Center. This is an 80-year-old male patient, is scheduled on regular dialysis for many years, and he is currently suffering from stroke, quadriplegia, and incontinence, dementia, hypotension, and shock. And this is the CT scan showing the aneurysm here and a big infarction. So a big infarction, dementia, and the poor cardiovascular tolerability. This was his last state. So if you have a patient like this, would you like to continue dialysis? And what will be the obstacles in deciding these patients? Actually, the major obstacle in this patient was his daughter refused to discontinue dialysis and insisted on continuing dialysis until the natural end. And when we explored the daughter and we explained to her the situation, she said that I am afraid if I shared your decision to stop dialysis for this patient, I'll be guilty because I shared in the process of active death of my father. So in this situation, we followed the middle of the road approach. So we said that we can give him another 2 weeks to assessing him if there is any improvement or not. And after 2 weeks, there was no improvement, and eventually the daughter agreed with us to stop dialysis, and he died 10 days after stopping dialysis. So this is a situation. To start is or not to start is a difficult situation. To stop is more difficult. But when we follow the patient perspectives and when we encourage advanced directive, this may help us to solve these problems. So hard choices and better outcomes. A review of shared decision making. So we should encourage shared decision making and patient decisions aids around dialysis initiation and conservative kidney management, because medicine has evolved from doctor-centeredness to disease-centeredness and currently patient-centeredness. So planned holistic patient-centered care for patient with GFR category stage 5 chronic kidney disease, including intervention to delay progression of chronic kidney disease, shared decision making, active symptom management, detailed communication, psychological support, social and family support, cultural and spiritual domains, all these together to help in deciding. And we may select and we may agree about the conservative treatment of renal failure. So a patient-centered approach to health care incorporates patient preferences, priorities, and values into decision making, and all these are of paramount importance and may sometimes contradict guideline driving care. Patient-centered care outcomes are those important to individual patient, not only those relevant to the disease interest. The necessary tools for providing patient-centered care include the ability to interpret and apply evidence to individual. More patient-centered approach may be facilitated by better understanding of the unique challenges that nephrologists face implementing patient-centered outcome in the care of patients on hemodialysis. So we need a tool to define and apply patient-centered, and we should increase the awareness of doctors and the doctors working in dialysis regarding all these issues. And the second point for the patient-centered approach is to encourage advanced directive and end-of-life care among nursing home residents receiving maintenance dialysis. So compare the content of advanced directives among 30,000 nursing home residents receiving dialysis to 30,000 nursing home residents with other serious illness during the year before death. Here, what do you see? Here, this color reflects surrogate present, treatment limiting directive present. So this is the advanced directive from patients and his surrogate are present. And this is the bright blue, surrogate absent, treatment limiting directive present. And the light color reflects surrogate present, treatment limiting directive absent. So if we have both surrogate present, treatment limiting directive present, the need to hospitalization, ICU care, intensive procedure, inpatient death, all these are significantly reduced. So this is the dialysis discontinuation increased too. So again, we should encourage the patient perspectives and directing the patient toward writing and documenting his advanced directive. Regarding renal transplantation, we shouldn't decline the idea of renal transplantation in older kidney transplant recipient, according to this study, felt able to enjoy life and strived to live at their newly re-established potential and capabilities, which motivated them to protect their graft. However, some felt constrained by slow and overwhelmed by unexpected comorbidities, medication-related side effects, and health decline. And the finding of this study suggested that the need to prepare and support all the recipients for self-management responsibilities, clarify their expectation of post-transplant risks and outcome, and provide assistance through prolonged recovery after kidney transplantation. Another interesting point, how to manipulate immune suppression in elderly, because it's very important. This is a very recent study, still just accepted article, discussing the issue of pharmacokinetics of tacrolimus, one of the most commonly used calcium inhibitors after renal transplantation. Here, in comparison to the young recipients, all the recipients need lower dose of tacrolimus to achieve the same level. This means that there is difference in pharmacokinetics and metabolism of tacrolimus in the elderly. But we shouldn't apply this rule to all immune suppression, because this is a recent study discussed the issue of pharmacokinetics and pharmacodynamics of mycophenolate mofetil, which is commonly used antiproliferative drug after transplantation. Here, this is the inositol monophosphate dehydrogenase on baseline, area under curve at different times, and here the age group. Again, there is no significant difference in any pharmacokinetic or pharmacodynamic parameters despite there is significant difference in age. So there is no difference between young and old regarding the MMF. So this study added to our information that inositol monophosphate dehydrogenase activity pre-transplantation in absence of microphonic treatment is not different between elderly and younger patients. This study showed that the age of the patient doesn't significantly affect pharmacokinetics or pharmacodynamics of microphonic treatment. So we should put this in our mind. And based on this data, no age-dependent dose adjustment needed to be implemented for the use of MMF in elderly. So all these are the important point to put in consideration when we prescribe immune suppression in elderly. So what I covered up to this moment is that there is increasing of accumulation of this sector of persons within the community over the world. So the world is aging. The kidney by aging shows many differences. So decreasing number of functional nephron, decreasing GFR, increasing cysts, increasing sclerosis, reducing reserve. Chronic kidneys in elderly is quite common, and even the definition is challenging, and we should tackle the association of the diet and drug. Blood pressure is very important to be, and here I stressed today about the proper management. So it's better if tolerated to reach the goal of 130 millimeter mercury, and because it seems that it's associated with lower cardiovascular problems. Drug use in elderly are commonly abused, and we should strive to proper use drugs, and even we can de-prescribe some medication like proton pump inhibitors. Biopsy when indicated should be done because it will direct our management, and I presented that there is a differential pathology in comparison to the young patients to the same indication of biopsy. AKI is common, especially if there is dehydration, so we should be careful about assessment of volume status and using drugs that increase this issue. Frailty is common in these patients, and we should assess frailty and encourage exercise if possible, using the best tools to assist the patients to determine the best approach for renal replacement therapy. We shouldn't decline transplantation or dialysis because of aging. We should look at the patient perspectives, their assessments, proper education, and the best timing for vascular access. To finish the presentation, I want to stress upon the most important point that I discussed with you, which is patient-centered care. Although this was the perspectives of older kidney transplant citizens of kidney transplantation article, but we can take all these points to apply in all domains of nephrology and even in dealing with geriatric persons. Practical support, assist with mobility if functional limitations are present, walking aids, daily exercise training to prevent falls, assistance if help is needed in daily activities and household management, provide practical reminders for medication adherence, organize transport to and from the hospital to attend appointments, physician-patient communication, engage in process of shared decision making. This is of paramount importance. Engage in a shared dialogue about realistic expectation and post-transplant outcomes and dialysis outcome. Use motivational interviewing techniques, utilizing communication framework as spikes, setting, perception, invitation, knowledge, emotion, or empathy, because empathy is a drug. Setting up the interview, assessing the patient perception, obtaining the patient's invitation, giving knowledge and information, but with more dignity and compassion to the patient, addressing the patient's emotions with empathic response, address information, concerns by using this technique, ask, tell, ask. Ask what is your understanding of your current illness, tailor the information that addresses patient's concern and needs. Ask to make sure that I explain things well. Can you tell me what you understand of what I just said. So a lot of communication, a lot of looking at the patient's perspective is of paramount importance. Advanced care planning is important and essential. Symptom and assessment and management, incorporate regular symptom screening. Symptom management requires stepwise approach, reevaluate and redirect treatment. Social support, psychological support, and health care delivery. If other comorbidity distressing symptoms and complication arise, deliver coordinated and multidisciplinary care for adequate pain and symptom management. So this is all what I have. At this point, I want to say that dealing with the geriatric is very difficult. Although it is difficult, but when we know the tools and when we master the tool, difficult routes often lead to beautiful destination. Thank you very much for your listening, and I'll be happy to receive any questions on my email. Thank you. Goodbye.